Hi friends, welcome to Medicomellu. So after a gap, I am coming with a video. Small topic, but a very important topic, that is anemia in pregnancy. I have made this note with recent guidelines and updates. So let's start. Anemia in pregnancy, it is a group of diseases characterized by low oxygen carrying capacity of blood due to three reasons. Can be due to three reasons. It's low RBC count, or abnormality of RBC, or any abnormality of hemoglobin. So these three can be the cause of anemia. So from this low RBC count, there comes the iron deficiency anemia, then anemia due to blood loss, everything comes under this. So these three reasons are there. So according to WHO and ICMR, the hemoglobin level less than 11 is taken as the cutoff, or the hematocrit value less than 33%. This is taken as the cutoff by WHO and ICMR, whereas the CDC takes cutoff as 11 for only first trimester and third trimester, whereas they take cutoff less than 10.5 for the second trimester due to the physiological hemodilution taking place in the second trimester. So not to worry if the patient is having 10.5 hemoglobin in the second trimester, says the CDC guidelines. Okay. So the causes can be broadly classified into acquired as well as inherited. Acquired causes can be deficiency due to iron, that is iron deficiency anemia, or it can be megaloblastic anemia due to deficiency of vitamin B12 and or folic acid. It can be due to any blood loss. It can be due to acquired hemolytic anemia. There is inherited hemolytic anemia also, that comes under inherited causes, but here it is acquired hemolytic anemia. Any bone marrow suppression need not be inherited, but a patient can manifest this bone marrow suppression in a later stage of life due to any stimulation, due to any drug intake or any other causes, but the patient may be having some vulnerability towards or for developing this bone marrow suppression. So we are taking it as acquired only because it is developing in the later stage of life. So it can be Fanconi's anemia, it can be aplastic anemia, or it can be pernicious anemia also. There is a controversy whether we have to take these are inherited or acquired, but here we are classifying it as acquired only. So next, the inherited causes is thalassemia, that is sickle cell anemia, hereditary spherocytosis, hemolytic anemia. So this is the broad classification. And here we are going to discuss mainly the iron deficiency anemia, which counts for around 80 to 90% of this anemia in pregnancy. In India, our mothers are prone for anemia mostly because of this iron deficiency. So this is a flow chart. This is a diagrammatic representation of the pathophysiology of iron absorption. So we are taking the iron in the food. It has got a heme iron component as well as a non-heme iron component. Non-heme iron component is Fe3+, and that gets converted to Fe2+ by a ferric reductase enzyme. Whereas the heme iron, it is transported into the intestinal mucosa by the heme transporter. Whereas this ferric reductase reduces the Fe3+ to Fe2+, and this Fe2+ is transported into the intestinal mucosa by the divalent metal transporter DMT1. So inside the intestinal mucosa, these two combine and forms the mucosal ferritin, and this mucosal ferritin is transported into the blood by the ferroportin 1 channel. And this is very important. The ferroportin 1 channel, it is involved in the regulatory mechanism of the iron absorption. So this ferroportin channel is controlled by the enzyme, the hepcidin, and this hepcidin is produced by the liver. So the hepcidin inhibits the ferroportin channel. Once it is inhibited, then the iron absorption is also inhibited. So here, let's say the iron absorption is taking place and ferroportin channel is active. There is no inhibition by the hepcidin. So this iron Fe2 plus is absorbed into the into the blood in the form of Fe3 plus, where the hepcidin it converts Fe2 plus to Fe3 plus. And this Fe3 plus in the blood, it combines with the plasma transferrin, it forms the plasma transferrin, and it is transported into all our organs, including the bone marrow, mainly the bone marrow, for production of for the erythropoiesis, for the production of blood, that is the erythropoiesis. Mainly the RBC production is known as the erythropoiesis. So this plasma transferrin levels, they give the information to the liver, and that gives the feedback mechanism for this hepcidin production. Okay, so let's say once, let's say here in anemia, the patient is having lesser iron stores, so the plasma transferrin levels are also lesser. So they doesn't give any feedback to the liver, so the hepcidin is not at all produced here, or produced in lesser amount. So there is no inhibition of the ferroportin channels. So hence the iron absorption takes place smoothly. Once the patient's iron reserve in the body or in the blood is higher, then this inhibition takes place. The plasma transferrin communicates with the liver and says, oh, we are having plenty of serum iron, so we can stop the absorption of the iron. So the liver sends the hepcidin, and it inhibits the ferroportin, and hence the iron absorption is inhibited at the level of the intestinal mucosa itself. Okay, so this is what is happening in the pathophysiology of iron absorption. So coming to the iron deficiency anemia, why it is a hot topic, why it takes place? Because there is an increased demand for iron, okay, in pregnancy. The total requirement in normal pregnancy is around 900 to 1000 milligrams. So in the first trimester, the mother needs 0.8 mg per day. In second trimester, the mother needs 4 mg per day, whereas in the third trimester, the mother needs 6 mg per day. So the highest requirement is the third trimester, where there is 6 mg per day. So that is there, okay. And the thing is that there is only 5 to 10% of the absorption of dietary iron. So if we are taking, say, 60 mg of iron, out of that 10% iron is absorbed, so only 6 mg gets into the blood. Okay, so that is the 10% or maximum 10% of absorption. So for the 6 mg of iron, we have to take around 60 mg of iron daily. Okay, we can come to that later. Next is, there is dietary deficiency. We have seen that there is increased demand of iron, we need more amount of iron, but we are having a deficiency in the diet. There is the diet with low iron content, and even if we are taking the iron, that iron is not readily available for absorption. That is the low bioavailability also. So next, there is poor absorption that we have seen. The absorption is inhibited by the phytates, tannins in the tea, polyphenols which is present in the coffee, phosphates, oxalates, and antacids. They reduce the absorption of iron. Whereas iron absorption is increased by ascorbic acid, citric acid, and also by the gastric acid. So there is poor absorption due to these inhibitors. And next is that we all have a low reserve of iron in the body because of the childhood and adolescent malnutrition, and the pregnancies will be of short interval. Okay, if the multiple pregnancies are of short gap or interval, then there is no much time for the mother's body to replenish her iron stores. So that is the reason. Multiparity, the same thing. And pre-pregnancy disorders like abnormal uterine bleeding. If the mother is having or was having any bleeding disorders, in that way also many blood might have lost. Okay, so that amounts to the low iron reserve. And another thing is there is increased loss, another possibility due to hookworm infestation, malaria, or bleeding manifestations, etc. So these are the common causes of this iron deficiency anemia. There is increased demand for the iron. Even at high demand, we are taking lesser iron, that is dietary deficiency. Even if we are taking the less amount of iron, even that is not being properly absorbed, that is poor absorption. And from childhood itself, we are having a low iron reserve, or due to multiple pregnancies without any gap, that also can cause low iron reserve, and there is increased loss also by many other ways also. So we can classify the iron deficiency anemia into mild, moderate, severe, and very severe. But according to WHO, only moderate, severe, and very severe anemia is there. So just remember the cutoff value is 7 and 4. Okay, 7 and 4, just remember. So if it is more than 4, if it is less than 4, it is very severe in both the cases, both in ICMR as well as in WHO. If the cutoff value, the iron, that is the hemoglobin levels, less than 4, it is very severe. Between 4 and 7, it is severe only. Okay, it is over and so it is severe. Less than 4 is very severe. So if it is more than 7, there comes the slight difference. So we have seen that both WHO and ICMR takes the cutoff as 11. Okay. So according to WHO, between 7 and 11, it is moderate. According to WHO. But according to ICMR, there comes another cutoff value of 10. So between 11 and 10, they say it is a mild anemia. And then 7 to 10, it comes to moderate anemia, as similar to the other WHO also. So this is slight difference in the ICMR and WHO. So coming to the stages of anemia, initially there is depletion of iron stores. Then there comes the iron deficiency without anemia. And lastly, what happens? There comes the iron deficiency with anemia. That is iron deficiency anemia. Clinical features, there can be signs and also symptoms. So symptoms are there can be fatigue, it can be giddiness, the patient complains of headache, palpitation, exertional dyspnea while walking, and the patient also complains of sleep disturbances, or that is insomnia. If it is severe anemia, then the patient can also develop congestive cardiac failure. What are the signs? There can be pallor while we examine the patient. In general examination, there can be koilonychia, brittle nail, there can be angular stomatitis, tongue may be glossy with lingual papillae atrophy, and if it is severe, then signs of congestive cardiac failure and hemic murmur also can be heard. Okay, coming to the complications, there can be maternal complications as well as fetal complications. So coming to the maternal complications, the patient can develop preeclampsia, anemia. Next, susceptibility to infections. The mother can develop infections. The mother's immunity is reduced. Poor tolerance to blood loss, if it is APH or PPH. Because the patient is having anemia, even a small quantity of blood, if it is lost, then it can cause APH or PPH. The APH and PPH actually doesn't count the amount of blood loss, actually counts the proportion of the blood loss. If the patient is having anemia, severe anemia, even a small quantity of blood loss can make the patient sick and go into shock. Dysfunction of labor, abortions or IUD, thromboembolism, puerperal sepsis, and preterm labor can also cause So let's see the fetal complications. Again, the IUGR, the development of the baby is compromised. There can be prematurity, preterm delivery causing the preterm baby. There can be perinatal mortality also because the mother's blood is supplying all the nutrients, all the essential things for the baby, for the fetal growth also. So if there is maternal hypoxia, there can also be fetal hypoxia and fetal distress also seen. Low birth weight, poor mental performance of the child after delivery or in the fetus, late childhood and all. Low iron reserves in the child, infantile and childhood anemia of the baby. So we have to diagnose. How we diagnose? We have seen the HB as so and so less than 11. So it is anemia. We have found it is anemia. First, we can call for a peripheral smear and look for the features. If it is microcytic hypochromic anemia, it is mostly, or it says iron deficiency anemia only. Okay. Then we have to call for serum iron, then send for serum ferritin levels, transferrin saturation, TIBC, etc. And look for all these for counting the iron reserves. Okay, the iron pathophysiology of the body. They say the story. Okay, next in the URE, urine routine, we have to look whether there is any RBC or the patient is having hematuria and all. We can see in URE. Stool routine also. If there is any occult blood loss, we have to see occult blood loss. And also, if any infestations of hookworm, we can also see the cyst. In renal function test, in case of any chronic renal disease, where the erythropoietin hormone levels are reduced, so the erythropoiesis is compromised. In Coombs test, to look for any autoimmune hemolytic anemia. Okay, coming to the management, we have to give prophylaxis for iron deficiency. So what are the prophylaxis? Mainly the nutritional supplementation. Provide adequate iron containing diet with more protein, vitamin C containing food also. So vitamin C and that is citric acid, ascorbic acid, all promotes the absorption of the iron from the diet. Next is the pharmacological management, pharmacological prophylaxis. Okay, there we are giving the iron supplementation, folic acid, and vitamin B12 and vitamin C are also provided. And deworming can also be done. Has to be done at least a single dose of albendazole in not in pregnancy, usually before getting pregnant or in the while the patient is planning to get pregnant. So the prophylaxis of the iron, okay, the iron prophylaxis. The WHO and MOHFW are suggesting two different dosages of the iron prophylaxis. So WHO says 60 mg of the elemental iron, that is ferrous sulfate, with 400 microgram of folic acid daily for 6 months during the pregnancy and 3 months after the pregnancy. So that is what WHO says. So 60 mg plus 400 microgram daily for 6 plus 3. Okay. Whereas the MOHFW says 100 mg of ferrous sulfate with 500 microgram of folic acid to be given 6 months of pregnancy and also 6 months postpartum, and that has to be given with vitamin B12 15 microgram daily and also vitamin C of 100 mg per day. The MOHFW also suggests this vitamin B12 and vitamin C to be given daily. So this is the prophylaxis of iron. Next, we have got a patient with anemia diagnosed and we have to treat the anemia. So there comes the therapeutic dosage of iron. So orally, first we have to give oral iron. 200 mg of elemental iron we have to give, that is the ferrous sulfate. Rest is the same with 500 microgram folic acid and vitamin B12 and vitamin C. This is by the MOHFW guidelines that has to be given for a minimum of 100 days after the first trimester. So this is the treatment: 200 mg of elemental iron, that is ferrous sulfate, with 500 microgram folic acid. That is double the dose of prophylactic dosage of iron. Okay, this is according to MOHFW guidelines. Next, the patient is having either severe anemia or the patient is not improving with oral iron. Then we have to go for the parenteral iron. So what are the indications for the parenteral iron therapy? There is poor compliance of the oral iron, poor oral absorption of the iron, intolerance to oral iron, moderate anemia if it is seen in early third trimester, then for the moderate or severe anemia at late pregnancy with blood transfusion being contraindicated. Okay, and or in cases of 4 weeks of oral iron therapy without any response. We have given 4 weeks oral iron therapy, still the patient blood levels of hemoglobin are not improving, then also we can go for parenteral iron. So there are two main combinations. Okay, iron sulfate is there and ferric carboxy maltose, that is FCM, or also there. First we are going with iron sulfate. 200 mg of iron sulfate in 200 ml NS over 1 hour of maximum 200 mg we can give per day. So this has to be given very slowly because there can be an hypersensitivity reaction towards this. So we have to start slowly with 20 to 30 drops per minute. Then we can increase the speed with around 80 to 90 drops per minute. This can be given daily or on alternate days also. Many studies say that alternate days is more effective because daily if you are giving this iron sulfate, then the body blood levels of the hepcidin, you remember the inhibitor hepcidin levels will be increased. So that inhibits this iron absorption also. So there is another study. So that study says that alternate days of iron sulfate is enough. But we used to give daily also. Okay. The MOHFW suggests 100 mg of iron sulfate in 100 ml NS to be given for 4 days continuously, then taking a break of 2 to 4 days interval, then again another 4 days dosage in the second week. So 2 weeks of treatment the MOHFW suggests. Coming to the FCM, it is very short duration therapy. Immediately, very rapidly we can correct the anemia. Here 1000 mg of ferric carboxy maltose can be given in 200 ml NS over 15 to 20 minutes. See the difference here, only 200 mg per day has to be given. Here 1000 mg can be given in 15 to 20 minutes, but this has to be given once a week only. So for a patient coming from far distance for the antenatal care, here in this case if we are giving iron sulfate every other day or daily, we have to ask the mother to come for the injections. So it will be very difficult for that. But in FCM, once a week we can call the mother and give the injection, which can be given with 15 to 20 minutes only. It is well tolerated in pregnancy. There is no much hypersensitive reactions, but the problem is that it is slightly expensive. Okay, and also there is an adverse reaction, or the side effect is that there can be hypophosphatemia also. So that phosphate level has to be checked if you are giving the FCM. So the physician, the gynecologist can decide on what to give, iron sulfate or ferric carboxy maltose, according to the different needs of the patient. So other preparations are iron isomaltoside and ferric gluconate also. So indications of parenteral iron we have seen. What are the contraindications of parenteral iron? In which all cases we should not give parenteral iron? If the patient is in the first trimester, do not give or no need to give. If the patient has a history of allergy or anaphylaxis to the parenteral iron, then we should not give. If the patient is having chronic liver disease, we should not give. If the patient is having any active infection also, if we are giving the iron, then what happens? The infection may flare up. Okay, so these are the contraindications. Then lastly, blood transfusion. If the patient still has severe anemia, less than 7 in third trimester or less than 5 in all the trimester, whatever be the trimester, if the patient is having less than 5, then give blood transfusion if there is no contraindication to blood transfusion. Okay, and also in case of intrapartum hemorrhage or postpartum hemorrhage, if the patient is very sick or if the patient is going for any shock like features, then also we have to give the blood transfusion. We have to be ready with the cross matched blood. Okay, then during the delivery also we have to be ready with some things. We have to manage promptly to prevent complications of this anemia. So intrapartum management are before going for any procedure or before planning the labor for delivery, arrange cross-match blood. Okay, we have to give adequate fluid correction also. Then shorten the second stage of labor. The mother with anemia, severe anemia or moderate anemia, it's very difficult for her to tolerate the labor distress. She can go for hypoxia, and the baby can also go into hypoxia and fetal distress can occur. So we have to shorten the second stage of labor. Then active management of third stage of labor, AMTSL. That is, we have to give uterotonic drugs like oxytocin, controlled contraction, and uterine massage. All these to prevent in the postpartum hemorrhage. That is the bleeding, to control the blood loss. Then if at all there is any hemorrhage or PPH, immediately manage. Promptly we have to manage. Many hospitals are having PPH protocols. There are guidelines for PPH management that the center should be, the doctors and the staff should be ready with the PPH protocol also. Promptly we have to manage. Then postpartum management. What are the postpartum management? Watch for any bleeding. Watch for any postpartum hemorrhage. If at all present, promptly manage. Okay. Continue iron for 6 months postpartum also. It is according to MOHFW guidelines. Adequate nutritional supplementation for the mother and thromboprophylaxis. If her mobility is reduced, if she is taking rest in the house, if she is not able to walk properly and all, give adequate thromboprophylaxis also. Then spacing of pregnancy and contraception. It is very important. Give the mother some time to replenish her iron stores here. Okay, give her some time. The body needs rest. Give her adequate nutrition. Let the body take 2 to 3 years at least for her iron stores to replenish. Okay, then plan her next pregnancy. Okay, so these are the important points in anemia in pregnancy with many updates in the new guidelines. Okay, so any doubts you can ask in the comments. I'll try to bring more videos for you, and this process is a learning process for me also. Okay, thank you for all your support. Thank you.